Thank you everyone for attending today. It sounds like we have a great audience. My name is Thomas Pigott. I'm the Medical Officer Health CEO, Peterborough Public Health, and joined with me today here on Treaty 20 territory, Nogajiwanong, is Hallie Adder, who's our Acting Director of Health Promotion, and very honored to have our Board of Health Chair and Councillor from Hiawatha First Nation, Catherine Wilson, Katie Wilson, also join us, and it's a huge privilege that you were able to take the time to spend with us and to share your perspectives, both as our board chair and uniquely as a First Nation councillor from Hiawatha First Nation, one of the two First Nations we have a Section 50 agreement with. So I'm going to, before we get started, I think you have a slide here, Hallie, for our land acknowledgement. Do we? Before we get started with it, I will just, I think we have a lot of people, so maybe we can opportunistically do introductions later if there's time and questions, but I would like to turn it to you, Hallie, to introduce yourself, and then to you, Chair Councillor Wilson.
Thank you, Thomas, and thank you for everyone for allowing us to present to you today. As Thomas said, I'm the Acting Director for the Health Promotion Division, and one of the honors that I have is to sit on our Indigenous, or sit with, not on, sit with our Indigenous Health Advisory Committee and support the work that, Indigenous Health Advisory Circle and support the work that they do. Catherine, do you want to introduce yourself, and I'll move to the land acknowledgement?
Ani Bojo, Wigwaskwe Dijnikas, Wabjeshi Dodem, Hiawatha Donjaba, Michishagi, Anishinaabe, and Dao. Good afternoon, everyone. My name is Catherine or Katie Wilson. My Indigenous name is Birch Bark Woman. I am a First Nation councillor from Hiawatha First Nation. I'm really pleased to be here and excited to be part of the conversation. Miigwech.
Miigwech. Thank you, Katie. Hallie, you're on mute.
Oh, sorry. So thank you again. As I said, it's an honor for us to be presenting to all of you today. As a visitor on this land, I have an important responsibility to acknowledge the grounds on which we are privileged to work, live, and play. Peterborough Public Health is on the Treaty 20 and traditional territory of the Mississauga Anishinaabe. And I believe it's not only important to recognize First Nations peoples for their care for and teachings about the earth and our relations, but also to honor those teachings through our interactions today and every day. I also believe that acknowledging territory is only the beginning of cultivating strong relationships with First Peoples. We need to reach out to Indigenous communities to open pathways for dialogue. For Peterborough Public Health, our journey to a Section 50 has provided us with that path for conversations that have and will continue to serve to build deeper awareness and further strengthen our relationships. So today, in response to this group's request, actually, and their interest in Section 50 agreements, we're going to go over what a Section 50 agreement looks like in writing, provide a little history on how we got here, and then what the Section 50 agreement actually looks like in practice. And then I'll turn it over to Councillor Wilson, who will provide what it looks like from the Indigenous people's perspective. And then finally, Dr. Pigott will then offer some ideas for collaboration for us as a network to consider. For context, there are two First Nation communities, Curve Lake First Nation and Hiawatha First Nation, located within Peterborough Public Health's geographic boundaries. From this map of the county of Peterborough, you'll see that Curve Lake First Nation is located just northeast of the city of Peterborough, and Hiawatha First Nation is found just south of the city of Peterborough. So what is a Section 50 agreement? Section 50 of the Health Protection and Promotion Act enables First Nation communities to enter into formal agreements with boards of health, where the board agrees to provide health programs and services to members of the First Nation community. The agreement also includes that the First Nation Council agrees to accept the responsibilities within the health unit, such as a municipality does, which includes contributing to cost sharing, and they may appoint a member of the board, a member of the community to sit on the board. A Section 50 agreement can take many forms, ranging from an agreement for a specific service or just a couple of services, right up to a full agreement for full public health services. But really, the type of agreement negotiated really depends on the needs of the individual First Nation community. I want to draw your attention to the word may. I have highlighted it there in the slide. So while the Act allows for these formal agreements, it's actually loose in terms of a mandate. And whether an agreement can exist really depends on the needs of the First Nation community and the relationship between the community and the Board of Health. And that's where the journey begins. It should also be noted that a Section 50 agreement, or the Section 50 in the Health Promotion Protection Act, does actually not prevent an informal agreement or a memorandum of understanding to be negotiated between Indigenous communities and boards of health that may outline a process for delivering public health services more effectively to a region. On that note, as you all know, requirement 3 in the health equity standard for the 2028 Ontario Public Health Standards provides direction that public health units shall foster and create relationships with First Nation communities, along with the accompanying relationship with Indigenous communities guidelines. These documents really provide a platform for conversations and determining a need for an agreement, whether that is a formal one like a Section 50 agreement or an oral, informal agreement which may be like a memorandum of understanding. So the history of Section 50 agreement starts actually way back in 1967. An amendment was made to the Public Health Act at the time, stating that for public health purposes, an Indian band would be considered a township municipality, and the council of the band would be deemed the council of the municipality. Where it was geographically feasible, local health units could extend services to them. However, then in 1983, the Health Protection and Promotion Act was updated, and creating a formal process for First Nations to engage with boards of health, giving them the same status as obligated municipalities and granting them the right to appoint a member as their representative to the board. In 2002, Dr. Colin Dacuna, the Chief Medical Officer of Health at the time, recognized the importance of these agreements and wanting to encourage conversations, sent a memo to all boards of health encouraging them to initiate discussions with band councils to identify where there might be program and service needs that can be delivered by a public health unit. So for Peterborough, our journey actually started 56 years ago with the amendment to the Public Health Act. In 1968, right after the amendment was made to the Public Health Act, the Board of Health requested and received a provincial order of council And it officially recognized the wishes of Curve Lake First Nation and Hiawatha First Nation to receive public health services from the board and to participate in governance. Interestingly, the warden, who was a county representative at the time, was actually the person selected by the two First Nation communities as their sole representative on the board, which is not certainly the way it is now. Before the Health Protection and Promotion Act was created, there were numerous informal agreements between the Board of Health and the two First Nation communities. However, even with the new act, it would be still a long time before formal agreements were created and fully implemented here. And it certainly didn't happen all at once. Written agreements were executed, Section 50 agreements were executed between the Board of Health and the councils of Curve Lake and Hiawatha in 1995. But a representative from Curve Lake wasn't actually added to the board until 1998. And it wouldn't be until 2009 that Hiawatha First Nation appointed a representative to the Board of Health. So what does the Section 50 agreements look like locally? Well, in writing, they're actually fairly brief. There's a separate agreement between each First Nation community. However, they are really identical in wording and actually use a template provided to us by the Ministry of Health. The agreements include a statement of commitment from the Board of Health to make available to each First Nation community all of the Ontario Public Health Standards programs and services provided by Peterborough Public Health. And it also includes an agreement that Peterborough Public Health will incorporate the 4 principles from the Royal Commission on Aboriginal Peoples into all board First Nation collaborations. Those principles include mutual recognition, mutual respect, sharing, and mutual responsibility. And finally, the agreement states that the allocation of the Board of Health budget for public health programs and services from the two First Nations, just like it is with the City of Peterborough and the County of Peterborough, it's based on population data. So while in writing they're fairly simple, I believe that these agreements in practice are certainly much more dynamic. We have representations from both communities on our Board of Health, and they've been a part of the board, as I shared earlier, for a number of years now. And they provide depth and diversity to the discussions of the board. They are certainly committed members of the board, providing strong leadership and even taking turns as Board of Health, as a Board of Health chair. In 2015, Peterborough Public Health established a First Nations working group. And this was basically a subcommittee of the Board of Health. And its purpose was to discuss strengthening its relationships with Indigenous peoples. And it coincided with the Truth and Reconciliation Commission of Canada's calls to action that was released in that same year. And the goal of the committee was to deepen awareness, sensitivity, and meaningful actions on issues that are of relevance and public health importance to Indigenous people living within the Peterborough County and City Health Unit catchment area. At the time that it was established, the committee's membership was to have the Board of Health chair and a minimum of 3 board members with representation from Curve Lake and Hiawatha. And then between 2016 and 2018, membership expanded to include the larger Indigenous community, and so representations from Nogojuan Friendship Center, Nakicha, oh no, now I'm not going to be able to say it. Nikijawendida and other organizations were joined the committee. After this expansion, the First Nations Committee was renamed the Indigenous Health Advisory Circle to represent the broader representation and inclusion. Our long history with both First Nations and urban Indigenous people in the local area has influenced our relationships, so that our work with Indigenous partners has become fundamental to our daily work. To reflect this, we have included in our strategic plan a commitment to practice active allyship for Indigenous self-determination and health equity. Our staff would certainly articulate that our formalized agreements have inspired us to foster growth in cultural sensitivity and comfort level to work with both First Nations and urban Indigenous communities. They would also articulate that the valued relationships that we have with partners add meaning to their work, which extends to our ability as an organization to attract both staff and students interested in working with a health unit with these established relationships. We've also been fortunate to receive support from the Indigenous community for staff development, both formally in exercises like a blanket exercise and allyship training, but also informal mentoring, which is truly has been a true gift. And finally, we have developed effective partnerships to develop programs. To provide an example of what the collaborative programming has looked like, I'd love to share with you and describe our success in planning and implementing COVID vaccine clinics during the pandemic. Peterborough Public Health's response to the pandemic was led through the implementation of a COVID-19 interagency vaccination planning team. It's a bit of a title, but this was a high-level planning group that was created to oversee the vaccination strategy. And the team was made up of many organizations, including Curve Lake, First Nation, Hiawatha First Nation, as well as other Indigenous organizations. And there were several subcommittees that were created as well that also included the Indigenous community representation. Having these communities involved ensured meaningful participation in decision-making that would affect the interests of Indigenous people. And the mutual respect and appreciation for each other's abilities certainly allowed Peterborough Public Health, both First Nation health departments, and the Urban Indigenous COVID Working Group to successfully implement a large number of clinics together. We all worked really hard to offer vaccine clinics that were accessible, felt safe, and welcoming for Indigenous peoples. When we were reflecting on our success, one of the members of the Urban Indigenous COVID Vaccine Clinic Working Group felt that due to the high level of trust that existed between all of the partners, we were really proud to believe that our COVID response was quicker than the rest of the province and maybe even Canada. So at this point, I am going to hand things over to Councillor Wilson and allow her to share allow her to share the perspective of Indigenous peoples on our agreement.
Thanks, Hallie. So at a past Indigenous Health Advisory Council meeting, members were asked to share their perspectives about the Section 50 agreement. There was an acknowledgement that the Section 50 was added prior to the Truth and Reconciliation Commission calls to action. And while it facilitates First Nations to have representation on the Board of Health as sovereign nations, it has no language for off-reserve Indigenous peoples. Therefore, governance representation of off-reserve Indigenous peoples is lacking from the Board of Health. However, locally, the creation of the IHAC committee does allow for their voice to be heard and shared. It should also be acknowledged that there is a lack of provincial representation of Indigenous peoples and nations in the public health system. Members expressed that this agreement has provided the foundational work of building relationships and developing trust that started with First Nations and has grown to include the larger Indigenous community, which has increased equity and inclusion. Members of the IHAC feel that the relationships between the Indigenous communities feel progressive compared to other areas of the province. They describe ourselves as a unique territory as the whole Indigenous community, our recognized First Nations, and our urban Indigenous population gets along, allowing for better collaboration and support. Something I would say in regards to the truth and reconciliation is a term that we use often in our community, and that's truth and reconciliation. So if we are really truly trying to be allies and to work in partnership with our First Nations and local Indigenous peoples, what are we doing as a whole, as a group, to support and foster those relationships to come to better understanding and provide better service that is required for those citizens.
Sorry, I muted myself again. Thank you, Katie. And now I'll pass it over to Thomas, who has some thoughts about how, as a network, we might be able to do some collaboration.
Yeah, thank you, Hallie. Thank you, Chair Wilson. I wouldn't say I have as much as thoughts as I'd like to help facilitate along a discussion, because I think that if I personally reflect, one of my interests in coming to this health unit about a year and a half ago was that this was front and center of their strategy, and was of the utmost importance to recruitment of a new medical officer of health. And these relationships, I think, are very valuable and quite critical. Well, I think anywhere you can have meaningful partnerships and relationships. What I've seen so far is that formalized governance accountability does ensure that it is not an afterthought or a nice potential collaboration if there is capacity, but that it's core to mandate, and it's core to the function of our Board of Health and our entire organization. And so I think in our context, and I can't speak for other contexts, the Section 50 agreements have really helped. And through the COVID-19 pandemic, I think they have not only helped to ensure the relationship with Hiawatha and Curve Lake First Nation, but also to ensure that there was stronger engagement than otherwise may have happened with other Indigenous populations in the region through the means described here. I think governance is obviously complex, but it is important if we're serving First Nation communities. When I was in my previous role, I felt it was something that was sorely missing in a region of the country where there was health and public health services provided to Indigenous communities. However, we had a health authority board that had exactly zero board members who themselves identified as Indigenous, and it showed in the priorities and the language and the decisions made. And so I think that it is quite important. I think there will be very different contexts across the province, and I'm sure many have entered conversations or have started the journey to figure out what makes sense and what works for them. I want to point out and thank Dr. Douglas, who's a public health physician, Lloyd Douglas, public health physician with the Sioux Lookout First Nation Health Authority, who's joined, and I think their approaches to community well-being, which maybe if there's time and interest, Lloyd could speak a little bit to, or in a future meeting if he has the capacity to join, is also a very different and interesting approach and model. I think what we are trying to work with is colonial, settler governance and changing it. And so I think there's a lot of considerations. I certainly have and continue to learn a lot as I go and try to maintain the humility to correct when I step wrong or when we do not do something as well as we potentially could. But certainly my time here in Peterborough has it's been clear to me that we are grateful for these relationships that we do have. And so, I mean, I think I'd be interested in comments, questions, discussion. I'm sure we can continue to pick the wealth of Councillor Wilson's input and brain here while we have her as well. From that perspective. And then, as we close the conversation, I think it would be interesting to know where we could go from here, because our Board of Health in our latest strategic plan from last year that Hallie shared did actually highlight not only locally, but that they wanted to continue to promote broadly the critical importance of the Health Protection and Promotion Act, Section 50 participation of First Nations, and broader work committed to active allyship for Indigenous self-determination, health equity. And so I think that our organization wants to help, support. We obviously are continuing a long learning journey here locally, but I hope that this conversation and others that come, potentially even, looking at a position paper or alpha resolution, looking at continuing to support engagement with other boards of health or education sessions and or the Ministry of Health. I think, we're very open to how people think that we could continue to support. And again, we hope some of the context and history and reflections here today are helpful. So with that, I don't know, Katie, if you want to add anything else in reflection.
I would just say that I think that when you are trying to engage with First Nations, and I know from speaking with other public health units that sometimes there is a hesitancy from the First Nation. And I think it's those times that we need to just pause and really reflect on the traumas that they've endured, which causes them to not trust. And so that's really what relationship building is all about, and is being able to show them the want and the need and the desire to have a nation to nation relationship that acknowledges that they are sovereign nations of their own, and at no point have ever given up the authority to care for their own people or to provide service to their own people, or to be able to have conversations with those providers who have the ability, the human resources, the expertise to deliver it in a culturally compassionate and a culturally educated way.
Miigwech for that. Thank you, Katie.
Thomas, I see that Sherry has her hand up.